Hi, it's Dr. Merrill again. This is the second part of the vodcast with a discussion of the two cases and some more pearls about care of the elderly patient. Let's start with case number 1. This was Mr. M, a 90-year-old man with atrial fibrillation on warfarin, admitted for a GI bleed. He was transfused in the intensive care unit and is stable, but is now your patient on the ward and you are called for new confusion. His past medical history is remarkable for coronary artery disease, COPD, atrial fibrillation, a history of a CVA in the past, and type 2 diabetes on insulin. His medications include torsemide, metoprolol, glipizide, glargine, paroxetine, and Ambien. His warfarin is being held. We'll review the first two questions together. Number 1, you were called by the nurse for confusion. What is in your differential, and how are you going to assess this? Number 2, how are you going to manage his acute confusion? Here's how I think about altered mental status in an older patient. First, you want to determine whether it is chronic or acute by taking a history, often including collateral information from family members or other caregivers. Most chronic altered mental status in the elderly is from some form of dementia. On the other hand, most acute altered mental status in the elderly is due to delirium. Delirium is more common in patients with dementia, but they are separate entities. Delirium is acute, and the level of consciousness is usually impaired. Psychomotor disturbances are often present. Delirium is usually reversible, although sometimes it takes months to fully recover. In contrast, dementia is a chronic and progressive illness. Patients usually have a normal level of consciousness until very late in the disease. Psychomotor disturbances are less common. Dementia is usually irreversible. The best way to diagnose delirium is through bedside observation using the confusion assessment method, abbreviated CAM. You are looking for the following: acute onset and fluctuating course, and inattention, and disorganized thinking, or altered level of consciousness. The CAM is particularly helpful in diagnosing a hypoactive delirium, which can sometimes be confused with depression or fatigue. I'd like to emphasize that you need an attention deficit to diagnose delirium. This is an important feature. Another important point about delirium, not covered explicitly in the CAM, is that it is often related to an underlying medical condition. Some common precipitating conditions include infections and electrolyte abnormalities. Delirium is also often caused by medications. Inattention is often evident from direct observation. Can they hold their attention on you long enough to complete a simple conversation, for example? Can they complete a task, like figuring out which object in the picture is the TV remote and turning on the television, or do they keep getting distracted? A simple bedside test of attention is the digit span, in which you present random numbers, 1 per second, and ask the patient to remember and repeat them back. The inability to repeat at least 5 numbers back suggests inattention. Here's a short excerpt from a video of a patient with delirium in which the attention deficit is particularly notable. He also has some hallucinations, which are common in delirium. A slightly longer excerpt of this video is available on the website.
So how are things going here? How you doing? I'm over here. Can you look over here for me? Sir? Excuse me, sir. The doctor's over here. Can I ask you a few questions?
What?
Have you been seeing some things while you've been here?
Well, like I said, I hear a bird singing.
Your bird's singing, yeah?
I shut the TV off. It ain't the TV.
Okay.
It's something on it.
Have you been seeing birds in the room?
Yeah, once in a while.
Okay. How about any other animals?
Yeah,
What kind of animals are you seeing?
horses, cows, and camels.
Has that been frightening to you?
Huh?
Has
No,
that
I
been
don't pay no attention.
No tension.
Nope.
Okay. All right.
It drives you nuts.
It drives you nuts, though.
No, that's why I don't listen to it.
No, oh, yeah.
I don't hear nothing. Yeah, in Red River Valley, all kinds of songs like that. I shut the TV off, leave the TV, turn it on, go ahead.
Can you tell me the days of the week backwards, starting with Sunday, please?
Monday.
Go back.
Non-pharmacologic management is first line in the prevention or treatment of delirium as follows. Always treat the underlying cause when possible. Remove any possibly deliriogenic medications. Normalize the sleep-wake cycle, hydration, nutrition, and mobility as much as possible. Delirium often improves over time with these measures. Pharmacologic treatment with antipsychotics is overused in current clinical practice as the evidence for efficacy is slim, and it should be reserved for cases refractory to non-pharmacologic measures in which the patient is a danger to themselves or others. For example, they're attempting to pull out their dialysis catheter or hit a hospital staff member. I've listed some possible starting doses of these agents. Atypical agents are probably not superior to typical at low doses, and the agents should always be stopped when the delirium is resolved. The third question for case 1 was about pain management in the elderly. Acetaminophen is first line in older as well as younger patients for mild to moderate pain. We should avoid NSAIDs in the elderly because of GI and renal toxicities. I avoid muscle relaxants and tramadol because of delirium risk and low efficacy at tolerated doses. Opioids are appropriate for the elderly for moderate to severe acute pain in the short term, with the goal being improved function rather than completely eradicating the pain. I start at 25 to 50% of the usual dose in most cases, something like 2.5 milligrams of oxycodone. The second case was Mrs. G, an 81-year-old woman you are seeing in clinic. She has diabetes, hypertension, bipolar disorder, chronic back pain, chronic diarrhea, and is in clinic for routine follow-up when her daughter mentions the patient had recently had a fall at home. Her past medical history is significant for bipolar disorder, hypothyroid, and diabetes, with her last A1C being 6, coronary artery disease, and hypertension. Medications include atenolol, atorvastatin, Depakote, glipizide, metformin, levothyroxine, loperamide, and lorazepam. The first 2 questions are about fall risk and reducing the risk of future falls. Here are the basics of fall risk assessment. You should screen with 3 questions that I will present on the next slide. Then you should do a brief test of gait, strength, and balance, such as the timed up and go or 30-second chair stand. If the patient passes steps 1 and 2, they are low risk and should be rescreened once a year. If they don't pass, you should conduct a brief review of their fall risk factors and implement appropriate interventions with follow-up. Here are the fall risk screening questions. Have you fallen in the past year? If so, how many times and were they injured? Do they feel unsteady when standing or walking? And do they worry about falling? Here are 2 fall screening tests. One is the timed up and go, which is the most common test. It involves standing up from a chair without using the arms of the chair, walking 10 feet, turning around, and sitting back down in the chair. The patient should use their usual assistive device. A total time of more than 12 seconds suggests increased risk of falls. The 30-second chair stand is also a useful test, which takes up less space to conduct in clinic. More details are available on a website I'll show you soon. A focused physical exam in a patient with fall risk includes the following: orthostatic vital signs, visual acuity, a cardiac exam, a musculoskeletal exam including the back and lower extremities, and a neurologic exam including a cognitive screen. Interventions with efficacy in fall prevention include the following: an evidence-based exercise program, medication review with reduction of psychotropics, environmental assessment of the home by an occupational therapist, and vitamin D supplementation. The evidence is not definitive on this one, but the risk of harm is relatively low. The recommended dose is 800 international units a day. Strength and balance exercise is the most effective single intervention for reducing falls. This exercise program should be at least 50 hours total, such as 1 hour twice a week for 25 weeks, with a progressive increase in difficulty. Tai Chi may be particularly effective. Walking is good for older patients, specifically for cardiovascular health, but does not reduce falls. A really great resource is the STEADI toolkit put out by the CDC, available at the link on this slide. It has short videos describing the timed up and go and 30-second chair stand, as well as a fall prevention algorithm. The last question was what other elements of geriatric assessment might be beneficial to this particular patient. The most important one for this patient within the next few months would be a brown bag medication review. Other helpful screening might be cognitive screening, screening for urinary incontinence, screening of her vision and hearing as part of her fall risk assessment, and a discussion of her overall goals of care with completion of a durable power of attorney for health care and an advance directive. In a brown bag medication review, you ask the patient and caregivers to bring in all of their medications, no matter how frequently they use them. You then review each medication to determine the indication, whether the patient is taking it as directed, and think about side effects, whether the medication is still necessary, and whether it is part of a prescribing cascade. This picture is from an elderly patient I took care of in the hospital with a history of solid organ transplantation. His collection of current, previous, and occasional medications was too big for a brown paper bag. Here's a quick review of the essentials of rational prescribing in the elderly. You need to do your brown bag review to make sure you know exactly what the patient is taking and how. You should think about whether medications are contributing to the patient's presenting complaint. Look for drug-drug and drug-disease interactions. Ask yourself if the new medication is truly indicated, whether there are non-pharmacologic options, do the benefits outweigh the risks, and is this a prescribing cascade? When prescribing in the elderly, start low and go slow, starting at a low dose and increasing slowly is the rule. This patient would also benefit from a brief cognitive screen. The tool I use most often is the mini-cog, which consists of the following. Ask the patient to repeat and remember 3 words. Then ask the patient to draw a clock. Direct them to draw the circle, then put in all the numbers and set the time to 11:10. Ask them to recall the 3 words. The scoring is 1 point for each word, 2 points for the clock. A score of 3 or greater suggests no impairment. I like this test because it is quick to administer. Unlike the MMSE, it is not copyrighted and it is easy to remember. It has a similar sensitivity and specificity to the MMSE. It was validated in a multi-ethnic community sample and is less affected by level of education than the MMSE. The clock part provides a helpful visual when a patient has impairment. This was a patient who was insisting that she could live alone, but clearly had significant cognitive impairment based on a full assessment. To summarize, 3 important principles of geriatric care are as follows. Prevent geriatric syndromes, assess and maintain functional status, and avoid polypharmacy. Additional resources are on this slide. There are a few more on the PDF of these slides, which is available on the website. There's also a 1-page sheet of pearls on the website. Thank you for your attention, and I'm happy to take questions or comments by email.